In this presentation, we'll be discussing pediatric asthma as well as how to score your patient for treatment options. We'll be discussing the pathophysiology of asthma, assess the clinical presentation of a child in asthmatic exacerbation, navigate the diagnosis criteria for asthma, and also discuss the management. Asthma is one of the most common pediatric diseases, with 1 in 10 pediatric patients in the United States carrying the diagnosis. The disease commonly manifests as wheezing, breathlessness, chest tightness, and coughing, and it can cause significant morbidity and mortality. The underlying pathophysiology of asthma is reversible airflow obstruction. There are 3 main mechanisms that cause this obstruction: bronchoconstriction, inflammation, and secretions. Bronchoconstriction occurs through constriction of smooth muscles around airways and is mediated through parasympathetic muscarinic M3 receptors. Inflammation refers to airway wall edema and inflammatory cell infiltration in the submucosa, including eosinophils, activated helper T cells, mast cells, and sometimes neutrophils. And finally, increased airway secretions can narrow the airway lumen. These secretions are made up of mucus, the squaminated lining cells, and intraluminal eosinophils. Pediatric asthma is characterized by variable expiratory airway limitation and persistent respiratory symptoms, which include wheezing, recurrent, persistent cough that gets worse at night, cough that worsens with exposures to triggers such as laughing, crying, exercise, or tobacco smoke exposure, shortness of breath, chest tightness, and decreased level of activity compared to other children. In early asthmatic presentation, cough and shortness of breath may be the first finding. As the disease progresses and inflammation worsens, the airways begin to narrow and airflow obstruction ensues. This can lead to faint wheezing scattered throughout the lung fields on auscultation. As the severity progresses, wheezing will become more diffuse throughout all lung fields. Wheezing may develop a higher pitch as inflammation and airway narrowing worse. In severe asthma flares, breath sounds and wheezing become faint and distant. In the most severe asthma exacerbations, airway narrowing can become so serious that air fails to move within the lungs. As a result, wheezing can disappear completely on auscultation. This is an ominous finding on physical examination, suggesting impending respiratory failure. Diagnosing asthma for children aged 5 or younger can be challenging. Clinicians must rely on a pattern of symptoms indicative of asthma, in addition to family history and physical examination findings. Asthma often occurs in childhood and is influenced by both genetics and environmental factors. Most children who wheeze before age 6 will likely have their symptoms resolved. However, a subset of children, typically those atopy, a family history of asthma, and persistent symptoms at a young age may develop persistent asthma. A detailed history will help identify the triggers and severity. A chest x-ray is not required or recommended to make a diagnosis of asthma, but it may be done to rule out other conditions on the differential diagnosis. The chest x-ray in asthma is often normal, but may show hyperinflation, bronchial thickening, or atelectasis. Venous blood gas samples may be obtained for patients with severe asthma exacerbations as well. Because patients with asthma exacerbations are tachypnic, CO2 values are expected to be low. A normal CO2 may suggest that the patient is not effectively ventilating and that the patient is at risk for impending respiratory failure. As described previously, asthma is a result of bronchoconstriction, inflammation, and increased secretions. Each of the medications used to treat asthma targets one of these mechanisms. Bronchoconstriction is treated most commonly with albuterol, a beta 2 agonist which leads to smooth muscle relaxation around the airway. In more severe cases, intravenous magnesium sulfate is also used to address bronchoconstriction. Inflammation is addressed with various forms of steroids depending on the situation. Some children use inhaled corticosteroids daily. During an acute exacerbation, a short course of IV or oral steroids is given to achieve control. Finally, ipratropium can help reduce secretions as well as bronchodilate. Of note, many medications can be delivered via inhaler or via nebulizer. The mode of delivery is determined based on the patient's age and availability. Children presenting with an asthma exacerbation should undergo a rapid assessment, including a complete set of vitals and oxygen saturation. Essential observations include level of consciousness, anxiety, agitation, breathlessness, wheezing, air entry, accessory muscle use, and retraction. Each patient assessment should be measured against the respiratory score tool. While these severity assessment tools have been adopted into routine clinical practice in many centers, it should be noted that they all have limitations. They are somewhat subjective and sometimes do not capture the full clinical picture. That is why many institutions recommend initial and recurring assessments performed with two caregivers to get the most accurate representation of the patient's asthma score and determine the patient's treatment plan, as is the practice at Peace Health. In the emergency room, the severity of an asthma exacerbation and treatment options are generally determined by clinical assessment, aided by scales such as the respiratory score. Management for asthma at Peace Health will follow the Pediatric Asthma Treatment Diagram Emergency Department. Throughout a patient's visit, all assessments will be performed by two caregivers. All patients should receive oxygen to maintain saturations above 90%. Within the first hour, patients receive multiple treatments of an inhaled short-acting beta agonist like albuterol via nebulizer or MDI, followed by repeat dosing every 1 to 4 hours. Nebulized treatments are administered individually or continuously. Research comparing the efficacy of an MDI combined with a valve holding chamber to nebulizer delivery revealed that administration via MDI is at least as effective as a small volume nebulizer. The advantages of nebulizer use in children are the ability to administer humidified oxygen and ipratropium simultaneously. In pediatric asthma management, patient education is pivotal in deterring exacerbation and promoting optimal disease control. Central to this approach is educating both caregiver and child about asthma triggers, recognizing symptoms, and the importance of following prescribed treatment plans. Developing an asthma action plan tailored to the child's needs and level of asthma control provides a structured approach for managing exacerbations and adjustment treatments as necessary. Each institution may have their own asthma plan, but most follow the criteria of the CDC Asthma Action Plan or the NIH Asthma Action Plan. By integrating comprehensive patient education, medication management, and personalized asthma action plans, clinicians can empower families to proactively manage pediatric asthma and provide long-term outcomes. This concludes our presentation on pediatric asthma and patient scoring. If you have any more questions regarding pediatric asthma or would like some hands-on training on assessing and utilizing the pediatric asthma scoring tool, please contact your clinical educator.